Hello, thanks for listening to the Total Knee Tips and Pearls podcast. This is Adam Rosen, your host. I'm a fellowship-trained orthopedic surgeon who specializes in joint replacement. In these episodes, I'm going to share with you a lot of my tips and tricks and review classic articles and current implant designs. Thanks for tuning in, and on with the show. Hello and welcome back. This is Adam Rosen, and you're listening to the Total Knee Tips and Pearls podcast. So we're going to continue on with more classifications and talk to you today about the cement grade classification that was introduced by Barrack and Harris. The article was titled Improved Cementing Techniques and Femoral Component Loosening in Young Patients with Hip Arthroplasty, a 12-year radiographic review. This was published in JBJS-Br, 1992. Now, just of note to remember, these were treated with second-generation cement techniques, and all of these patients, when they said young, were less than or equal to 50 years old. So, I think in America, most hands are going to treat these patients with press-fit stems. And even though the data is quite good across the pond, cementing all patients, a lot of surgeons in America very commonly have gone away from cement. Me personally, when I started practice 15 plus years ago, I had sort of a cutoff. It was 75 and older, then it became 85 and older, and then I was using two main stems, more of a fit and fill stem and a blade type stem. And we'll get into that classification later when we talk about the door femurs, but I would kind of pick and choose, and with newer stems, the option of a collar with a shorter broach body, even in an older individual, a lot of times in my hands, I'm going press fit, for probably time, the lack of not adding an additional anesthesia to my older patients, potentially causing hypotension from the cement, getting them off the table a little bit quicker. But I still cement probably more than most of my partners except, one. And I think it's an important thing because, all of my hemis now I cement. I went through a phase years ago where I was press fitting a lot of my hip fractures, and, now I've gone to 100% cement for hip fractures. It's just due to the bone quality, but it's a lost art. I see a lot of people coming through. So definitely get in operating rooms with surgeons that are cementing, hopefully cementing well, but at the same time, if they're not cementing well, you can learn from their mistakes as well. And like always, we're always constantly learning. It's a lifelong learning experience. So you can't just leave the operating room and think that the thing is done. You really have to scrutinize your x-rays and recognize that, if you're not, grading your cement mantles as an A or B, you have to question as to why. So what they looked at and the things that are important for you to understand. So someone says, okay, well, you looked at the post-op x-ray. How would you grade your cement technique? Okay, so A is a complete fill of the entire canal, the typical, buzzword, the whiteout. So we like to see that. You like to see the cortex, complete bone cement, and the implant, no holes, air bubbles, gaps, lucencies, defects. So that is a grade A, whiteout. A grade B is a slight radiolucency. You may have a couple little spots here or there, but for the most part, pretty much is all full, but you have a couple little spots where maybe you had an air pocket or a little bit of blood got in there. But overall, still a good grade. Grade C. So grade C are radiolucencies along the bone cement interface, anywhere from 50% up to 99%. So you don't want to have this incomplete cement mantle and lucencies in more than half of the area surrounding the stem. That is a high risk of failure. And then a grade D, this is gross radiolucencies, almost 100% radiolucency around the entire interface of the stem. Also, failure to cement the tip of the stem. So you want to make sure you have a bone plug distance below the tip of the stem. If you ever have to revise and someone's got a 6 centimeter bone plug, under your breath, you're going to be cursing the guy that put it in or gal that put it in. But at the same time, if you are afraid of leaving too much cement distally and you short yourself and the tip of the stem is not in the cement or the cement ends right there, that's a D. That's not going to work well. It's going to fail. So typically for me, what I'm doing is if I'm doing a cemented stem and I put the centralizer on the end and I have my buck restrictor on the inserter, I'm doing 2 finger breaths below the centralizer to the top of the buck restrictor and then making a mark. And then I'm marking that, typically to the calcar and putting it down. And I'll tell you, even though it looks big on the back table on the Mayo, on X-ray, it never looks quite large. It right is in that 1.5 centimeter mark. So I make sure that I do that because I found that if you short it like a finger breath or you just get it a little bit below, lo and behold, it looks like the centralizer is laying right up against your buck restrictor, and now you have a D cement grade. Now, you may also be asked, and it's important to understand the differences. This article talked about second generation, cement techniques. So first generation was just hand mixing in a back bowl and finger packing the cement in place. Didn't do a good job of, pressurizing the canal and filling the canal. Second generation cement techniques were using a cement restrictor distally and starting to use a gun, and they started to brush and dry the canal. Third generation cement techniques are now the idea of vacuum mixing to improve the porosity of the cement and then pressurizing the canal. You've all attached that little blue pressurizer to the gun, so once you get it in the canal, you can pressurize it. And also prepping the canal, pulsatile lavage. A lot of people even recommend the idea of like a soaked sponge to constrict blood vessels. And I have a whole podcast in the first, I think it's the first or second season, which, and I'll see if I can add the link to the show notes, which goes through my cement technique. Really briefly, once we've gotten to the very, very end, it's wash, brush, dry, lidocaine with epi because it's easier than getting just pure epi, soaked sponge in the canal. Take that out, dry again, dry lap, dry, irrigation, and the right consistency of the cement all the way to the bottom of the buck restrictor, squeezing and letting the force push you on the way out. But I keep my thumb over the calcar so I feel that cement coming up against my thumb. So it's semi-pressurizing as I'm gunning it back. Once I get there, then add the pressurizer, pressurize a second time. And then I take the stem and hold my finger over the calcar and push it in. So I'm basically pressurizing a third time, usually stopping at a third and then 2/3 before I then go to the actual inserter and sink it all the way. And then you can't move. Anytime that you can't put it in and then adjust your version. So if you messed your version up on the way in, you messed your version up because then if you turn it to correct your version, now you've created a cement air void somewhere because you've modified that. So you have to make sure that your version goes in straight from the very beginning. But again, A, B, C, D, cement grading. A, complete whiteout. B, slight radiolucency. C, radiolucencies are an incomplete cement mantle of 50% to 99%. And a D grade is 100% radiolucency or failure to cement to the tip of the stem. So thanks again for listening. I'll put all the little summary in the show notes so you can glance at it if you need to quickly. And until next time, stay safe. You've been listening to the Total Knee Tips and Pearls podcast. I'm Adam Rosen. You've been listening to the Total Knee Tips and Pearls podcast. Make sure that you're subscribed so you'll be notified of future episodes. And please take the time to leave a review. It helps other people like you find the show. Until next time, stay safe.